Chapter 11, Health Information Exchange. Health information exchange is defined as the formal agreed-upon process for the seamless exchange of health information electronically between providers and others with the same level of interoperability according to nationally recognized standards. HIE requires a shift in the mindset for healthcare professionals from treating individuals within a specific practice or facility to understand how healthcare organizations impact the health of the entire community in which they practice. Value-based healthcare is an evolving concept focused on three areas: better care for the individual, better health for the community, and lower cost of healthcare through improvement of services and delivery methods. Interoperability is the capability of different information systems and software applications to communicate and exchange data. Interoperability must be both an internal and external application and can be difficult to achieve. There are four types of interoperability: technical, syntactic, semantic, and process. Technical is based on the hardware and equipment connectivity used in the exchange. This type of interoperability allows any computer or device to exchange data with another computer or device without corrupting the data or creating errors. Syntactic is message format standards that identify how the data should be formatted or structured to allow the exchange. Interface software, which is programming, must be employed for compatibility to enable the exchange. These interoperability standards are not specific to healthcare, as they are applied to any electronic transmission between two entities. Semantic: this process involves the use of standardized terminologies, such as SNOMED, to provide clarity, consistency, and appropriate meaning in the HIE. This area of HIE is still undergoing development. Process is perhaps the most difficult of all the types of interoperability. Process refers to the degree to which the integrity of workflow can be maintained between systems, and includes maintaining and conveying information such as user roles, data protections, and system service quality between systems. The American Recovery and Reinvestment Act, or ARRA, was enacted to stimulate the U.S. economy during a recession. A significant portion of ARRA was dedicated to expanding the use of HIT to improve the business efficiency and effectiveness of HCOs while increasing patient safety and positive health outcomes. The part of ARRA legislation is the Health Information Technology for Economic and Clinical Health, or HITECH, which dedicated more than $19 billion to developing HIT, implementing workforce education and training, certifying EHR products, establishing standards and vocabularies, and driving electronic security and privacy regulations into the 21st century. The HITECH Act was the foundational legislation for the development, adoption, promotion, and use of electronic and computerized applications to create an interoperable health information exchange system. The HITECH Act added new regulations and requirements, toughening enforcement and increasing penalties for security breaches and privacy violations. A health information organization is typically a public-private partnership organization that oversees, governs, and facilitates the transmission of health data between different types of HCOs that have various EHR systems, according to nationally recognized standards. Many HIOs started as local health information organizations, LHIOs, or regional health information organizations, RHIOs. The Health Information Management Systems Society, HIMSS, defines RHIO as a group of organizations with a business stake in improving the quality, safety, and efficiency of healthcare delivery that comes together to exchange information for these purposes. The terms RHIO and Health Information Exchange, or HIE, are often used interchangeably. An LHIO is a small-scale version of an RHIO. The Sequoia Project eHealth Exchange, originally known as Healthy Way, is a group of federal agencies and non-federal organizations that came together under a common mission and purpose to improve patient care, streamline disability benefit claims, and improve public health reporting through secure, trusted, and interoperable health information exchange. The Sequoia Project is a private sector organization. It provides exchange services in all 50 states for more than 1 million patients, 65% of U.S. hospitals, 50,000 medical groups, 8,300 pharmacies, and the Department of Defense, Centers for Medicare and Medicaid, Veterans Administration, and the Social Security Administration. Implementing and using current HIT and HIE has many benefits for healthcare entities, providers, patients, and society. This includes improve the quality of care, reduction of healthcare costs, use of clinical decision support software, increased public health monitoring and reporting and monitoring of population health trends such as a decrease in diabetic complications due to patient education and notification, increased use of mobile technology such as cell phones, tablets, laptops that can communicate anywhere and anytime. The new phrase, bring your own device, or BYOD, refers to healthcare practitioners using their personal smartphones or other devices rather than devices provided by the HCO. While acceptable, the personal device must meet specific encryption and other security protocols to protect PHI as required by the HCO. Additional benefits include increased and improved effectiveness and efficiency of healthcare treatments and business operations, improved connection between evidence-based health research and actual medical practice, and provides a basic level of interoperability among EHRs. HIT and HIE benefits for patients include patient safety, automatic appointment and health reminders, and saving patients time throughout the continuum of care. Other benefits include equity of treatment and services with improved health outcomes leading to a reduction of health disparities. Emergency and urgent care personnel can quickly determine the patient's medications, allergies, and medical history to aid in diagnosing current episode of care. And more engaged patient education and patient involvement in the decisions that affect their health. Benefits to society include decreased response time for disaster response. Many population public health issues have links to homeland security, such as newly emerging diseases such as Ebola and bioterrorism attacks. Public health surveillance of outbreaks or epidemics of large-scale foodborne illnesses, epidemics, pandemics of mutated influenza, and Zika virus spread. Also, alerts can be sent to appropriate government and health officials to speed response and mitigation efforts. This is particularly helpful when outbreaks or epidemics cross state lines. Barriers to implementing health IT are numerous and include financial issues of supporting the HIOs and HIE, and the increased cost of hardware and software, trained professionals, and infrastructure. Lack of complete operational and interoperability standards and vocabularies, and inadequate computer interfaces across all vendors and organizations. Healthcare information ownership between patients and providers is still in question, and patient identification and matching capabilities and protocols along the entire continuum of care. There are also competition and proprietary issues between HCOs. And finally, many rural hospitals lack financial stability and strength to provide new hardware, software, up to date IT personnel, and regional geographic infrastructure for reliable transmission of data. Meaningful use is an incentive program for eligible professionals, eligible hospitals, and critical access hospitals participating in Medicare and Medicaid programs that adopt and successfully demonstrate meaningful use of certified EHRT technology. ARRA and high tech specified three components for meaningful use, all requiring the use of a CEHRT. First, CHERT must be used in a meaningful way, for example, prescribing electronically and computerized provider order entry. The exchange of health information must be used to improve quality of health care. And finally, EHR must be used to submit clinical quality measures, CQMs, and other specified measures identified by the ONC and HHS. CQMs are criteria and tools to measure or quantify healthcare processes, outcomes, and patient perceptions. Organizational structure and systems that relate to one or more of the quality goals for healthcare, which are effective, safe, efficient, patient-centered, equitable, and timely. Meaningful use emphasizes population health reporting through aggregate data on immunizations, communicable diseases, and other health events. And CQMs that healthcare entities, providers, and public health agencies are required to report is a standard function in EHRs. Research on the state of health outcomes show disparities between genders, race, and socioeconomic status. A health disparity occurs when there are unequal differences in health access, status, or outcome based upon factors such as gender, race, socioeconomic status, sexual identity, orientation, disability, and geography. CMS has given priority to research and development of action plans that address health disparities in the following populations: racial and ethnic minorities, immigrants and those with limited English proficiencies, individuals with low health literacy, the socioeconomically disadvantaged, disabled and those with special needs, older adults, rural residents, children and adolescents, and lesbian, gay, bisexual, and transgender people. HIE architecture refers to the configuration, structure, and relationship of hardware in an information system. There are three types of HIE architecture that are most commonly used in the United States: consolidated or centralized model, the federated or decentralized model, and finally the hybrid model. The consolidated, also known as the centralized model of HIE, was typical of the early years of HIE. Many independent HCOs connected with the HIE, and aggregate data was stored and shared within a central repository managed by the HIE. This centralized data has a master patient index or a record locator service, also known as an RLS. An RLS indicates where the patient's information is detected within the participating HCOs based on patient identity information and record data type. Each HCO can access the appropriate information from the centralized data repository of the HIE. Advantages to the consolidated model include consistency of the data availability and rapid response to requests. Disadvantages to this model include duplication of data, data that is not completely up to date, and costs for supporting software. The federated model, also called the decentralized model, is not a centralized database of patient information. It works much like the internet. Each HCO is responsible for maintaining its own patient's health record. The HCO uses criteria to determine which external entities have authorized access to the HCO's health information. The external entities are vetted for their authority and security mechanisms to access the health information. The federated or decentralized model is much like the internet. There is no centralized database of patient information. Each HCO is responsible for maintaining its own patient health records. It also uses an RLS. The RLS tells the requesting provider/organization which other participating HCO has the patient information. The requesting provider initiates a query through the HIE to the identified HCO that controls the patient information within the HIE. The responding HCO then replies to the requesting provider through the HIE with the specified patient information. The federated model has several key benefits, including lack of data ownership. Because each HCO maintains its own data, the available data are always current, and this HIE has the capability to integrate with many EHR systems, providing redundancy or the use of additional or backup systems. Disadvantages include data availability problems due to technical issues of a specific HCO, and the data may not always be available or complete because the patient may have data distributed across many of the HCOs involved. The hybrid model combines the advantages of centralized and decentralized models. It has an RLS, and some data are stored in a central repository while the remainder stays with the other HCOs within the HIE. The hybrid model also has a patient portal to itself and not to a specific HCO. There are three methods in which health information is exchanged between appropriate healthcare entities or providers: directed exchange, query-based exchange, and consumer-mediated exchange. Directed exchange is frequently referred to as push exchange because it pushes authorized and secure information from one HCO to another. For example, if a patient is being transferred from one hospital to another, the patient's health information would be pushed to the receiving hospital in order to provide the background health information to help the transition to continued care. As part of Stage 1 meaningful use, the DIRECT project was initiated in 2010. The DIRECT project is important for the secure messaging and transmission of laboratory results, summary care records, referrals, public health reporting, and conveying quality measures. DIRECT project is a standards-based exchange platform to provide a secure, straightforward, scalable method to transmit encrypted information to collaborating providers. Direct messaging exchange acts like a regular email but with added HIPAA security mechanisms for protection of both senders and recipients with direct addresses. Direct Trust oversees the DIRECT project is a federally recognized nonprofit policy and governance body that makes it possible for direct exchange to operate smoothly and reliably, giving direct users much needed confidence in their exchange partners' privacy and security practices. Query-based exchange is a find and seek request for information that is sent through the HIO to find any available health information on a specified individual. It is the opposite of push exchange, so it is thought of as pull exchange. Consumer-mediated exchange is a type of HIE that is controlled by patients who want to control the use and access of their health information. Patients manage their healthcare online in a similar fashion as to how they might manage their finances through online banking. Patients can actively participate in their care coordination by providing other providers with their health information, by identifying and correcting wrong or missing health information, by identifying and correcting incorrect billing information, and tracking and monitoring their own health. Identity matching, also known as patient matching, is the process in which the HIO identifies the right person within the database to exchange information between HCOs. Congress has banned the Department of Health and Human Services from trying to develop and implement a national unique patient identifier. A common method for identifying matching is the use of algorithms. An algorithm is a way of solving a mathematical problem within a limited number of steps that often requires repetition of the step or a rule or a procedure containing conditional logic for solving a problem or accomplishing a task. The sophistication of the algorithm depends upon the type and amount of data needed to solve the query. Basic algorithms that compare selected data elements, such as name, date of birth, and gender, are the simplest technique for matching records. Intermediate algorithms use more advanced techniques to compare and match records by assigning subjective weights to demographic elements for use in a scoring system to determine the probability of matching patient records. Advanced algorithms contain the most sophisticated set of tools for matching records and rely on mathematical theory and statistical models to determine the likelihood of a match. Identity management is different from identity matching. Identity management ensures that the individual who has been identified is who they say they are, that they have the authority to do what they want to do, and that their actions are tracked, and involves the standard security functions of authorization, authentication, access control, and audit control. A component of identity management within HIE is consent management. Consent management has nothing to do with the consent for treatment, but rather the patient consents or approves the HIO to transmit health information between two or more authorized entities. Electronic consent management is a system, process, or set of policies that enables patients to choose what health information they are willing to permit their healthcare providers to access and share. Consent management allows patients to affirm their participation in electronic health initiatives such as patient portals, personal health records, and health information exchange. There are three components for implementation on electronic consent management process. Reference to Figure 11.5 of your textbook on page 196. The first, patient education and engagement, includes educating patients about their consent, who may release their information and how, and the significance of the consent choice. Technology is using technology to capture and maintain patient consent decisions, identify which sensitive portions of patient information are restricted from access, and communicate these restrictions electronically with others. Law and policy refers to ensuring alignment with federal and state law and other legal and policy requirements pertaining to consent, individual choice, and confidentiality. The process of obtaining approval or consent to transmit health information has two components. The first is to obtain consent from an authorized HCO or provider to electronically request or transmit any patient's health information to or from other authorized healthcare entities. The second component involves the patient consenting to have the health information accessed and released. This is typically done the first time a patient is registered to receive healthcare services. Opt-in or opt-out consent sets the default for health information of patients to be included in the HIO automatically. But the patient can choose not to be included, which is opt-out completely. Opt-in consent means that the patient must specifically agree to have the personal health information accessible for the HIE. Of this consent is the opt-in with restrictions, in which the default is no patient health information, which is automatically made available, and the patient must then define what information is to be sent, who it is sent to, and for what purpose the information may be used. The opt-out consent means that the patient data can automatically be exchanged within the HIO by default. A variation on this consent is the opt-out with exceptions model that sets the default for health information for patients to be included, but the patient can opt out completely or allow only select data to be included. The AHIMA work group has recommended specific data elements that help the HCOs and providers with patient identification issues. Some of the primary data elements include legal name, date of birth, gender, race, mother's maiden name, and primary phone number. Examples of secondary data elements are birthplace, marital status, social security number, driver's license number, email address, and some type of biometric. Biometric is a physical characteristic of the patient or users, such as fingerprints, voice prints, retinal scans, and iris traits, that systems store and use to authenticate identity of the patient or before allowing the user to access a system. All health information is private, but mental health diagnoses, drug and alcohol treatment, and sexually transmitted disease identification are considered to be particularly sensitive. The healthcare organization must determine what additional privacy and security protections are in place because some HIEs may not be able to adequately protect that sensitive information. Best practices addressing privacy issues with the HIE include workforce education programs that are robust and timely, including the right of the patient to request restrictions. All employees involved in any patient data or information transaction, access to EPHI, PHI, or HIE operations must receive regular and documented training regarding HIPAA and HCO rules, regulations, policies, and procedures. Up-to-date breach notifications, policies, and procedures for all HIPAA-covered entities. As recent news of data breaches and identity theft events have shown, the public's trust has decreased regarding the ability of an organization to safeguard their information. All mobile devices have effective and strong encryption protection. Application of breach sanctions are as written in policy and procedures. Depending on the level of breach, sanctions must have commensurate severity of consequences and be established prior to the event following HIPAA guidelines. Business associate agreements are analyzed, evaluated, and updated on a regular basis. The rules are continually expanded and updated, and the HCO must make certain it follows suit. Current risk analysis is implemented and revised on a regular basis. Follow up with business associates, covered entities, and any others must be verified by the HCO to be in compliance. And finally, request for restrictions on release of information by patients is implemented and on the notice of privacy practices. The enhanced privacy rule requires the HCO to have a method to note that the information has been restricted.